All right, so thank you everyone for being here when we all should be eating. So I'm going to be talking about my current IIR, Advancing Pharmacological Treatment for Opioid Use Disorder, and I'm going to be focusing on the early implementation phase of the project. Oh, yeah, I'll try. Okay, better? All right, so again, this really didn't show up well, sorry about that. But very brief background, because I think most everyone in the room is aware of the opioid epidemic. I don't need to go into that, but as Eric said, there are 3 FDA-approved medications to treat opioid use disorder: methadone, buprenorphine, and naltrexone. And methadone and buprenorphine are considered first line. Naltrexone is considered a second option for patients that may not want to continue on any type of opioid, or for some reason those medications aren't appropriate for them. So of the 2 available opioid agonist medications, only buprenorphine can be prescribed outside of specialty addictions treatment settings. So that's why VA is really focusing on improving access to buprenorphine, because it can be prescribed in primary care, office-based settings, general mental health, pain clinics, anywhere where patients with high-risk opioid use are seen. As Eric said, providers have to complete this additional training. It's 8 hours for MDs, 24 hours for nurse practitioners and physician's assistants, and then they have to request a waiver from the DEA in order to be able to prescribe. It's a huge barrier because that really raises people's fear about what this medication is all about. They think it's somehow more dangerous than the opioids they've been prescribing, which it's totally not. And they can only prescribe to 30 patients in their first year, and then they can go up to 100 patients in their second year, and they can go up to, I think it's 275 after that. So again, a capacity issue. If you're limited in the number of patients you can prescribe to, you need more people being able to prescribe. So the rationale for our particular study, VA has been focusing at a national level on increasing access to medication treatments for opioid use disorder for at least a decade, more than that, and has made a lot of progress in increasing the number of patients that are on evidence-based medication treatments. And as Eric said, we're up to about 40% nationally, but this is a graph of each facility in the VA, is a separate bar. And so the mean may be, I think this is from our baseline data, so this might be a couple years old, so the mean's moved up a little. But you can see the mean may be 40, but you've got some clinics way up there at 60 plus, and then you have the tail end of the clinics that are, below 10 or 20%. So we were really interested in focusing in on those facilities that were at the very lowest end of prescribing and figuring out why are they lagging behind like that. So that's the justification for the project. So we identified the facilities that were in the lowest quartile of the percent of patients receiving evidence-based medications. We stratified those by ultra low and low. So within that, they were all, I think, under 21%, but you've got less than 10%, and then you've got a little higher. And we also stratified by number of actionable patients. So if you're familiar with VHA metrics, SUD16 is the percent of patients who have opioid use disorder who are on a medication treatment. And so the patients that are in that denominator that are not currently receiving medication treatment are actionable patients, the ones that something needs to happen for them. So for some of those low prescribing facilities, their actionable patients might be a few dozen. And for some of those low prescribing facilities, they may be several hundred. So we thought there's going to be a big difference between some little rural facility out in Wyoming that has a few dozen patients to deal with and a highly urban facility like Miami that has several hundred. And so we randomly selected 2 sites from each of those strata with the hope of being able to look at implementation strategies and barriers and how they differed. So we initiated our contact with the SUD Specialty Care Clinic because we figured for these lowest performing sites, they may even need to be boosting up what they're doing within specialty care, let alone expanding out to these other clinics. And then we started our intervention with 2 sites per quarter over the course of 1 year. So our implementation strategy is really, the overarching strategy is external facilitation. But kind of step by step what we did for them, we started with a developmental evaluation. We interviewed at least 10 stakeholders at each facility. That would be SUD specialty care leadership and providers, facility leadership, chief of staff, chief of primary care, nurse care managers, and then providers in other clinics that either had an interest, so for example, like some of the homeless pact providers were really interested, or providers that might be pulled in to help, so pain clinic providers or primary care, general mental health. And then we did a 1.5-day site visit to each site. We provided the X-Waiver, the first half of the X-Waiver training on site, which was hugely beneficial. Dr. Gordon is my co-PI, and he is a phenomenal X-Waiver trainer, like really eases all those fears that people have, I think. He also provided other didactics around models for integrating this care into other types of clinics, like primary care, because that's what he does. And we also reserved at least 4 hours, like 2 at the very beginning and 2 at the end, to focus in on action planning. So we would go over the site report that we developed from our interviews. We did our interviews, put it together in a nice report, brought it on the site visit. They reacted to it, fixed things, added things, and then we actually came up with an action plan of like what are the top 3 or 4 things that you can achieve in the next year, who needs to be involved, what kind of a timeline are we looking at, what kind of barriers are we going to run into. So we left the site visit with a plan in hand. And then we spent the next year having monthly facilitation calls with them and providing them with quarterly feedback, and also providing on-demand as-needed consultation. So Dr. Gordon was available for clinical consultation, and I was available for implementation consultation. So I'm presenting the interim progress on quantitative outcomes. Like I said, the entire intervention was 1 year, and we have full 6-month data. Well, we have 6-month data on 7 out of 8 of our sites so far. So that's what I'm presenting today. So as I said, we stratified by prescribing rate, and now here you can see the actual numbers of where the cutoff points were. Prescribing rate and actual patients. Our quantitative outcomes, very similar to SCOUT, are the number of providers that are able to prescribe, the number of patients receiving medications, and then the SUD16 measure of the, oh wow, okay, of the percent. Is that 15 or 10? It's 10. Okay, good. All right. Okay. So then we assess the outcomes at each quarter, at each fiscal year quarter. So we compared the fiscal year quarter prior to the intervention start, prior to the developmental evaluation, and the fiscal year quarter that ended at least 6 months after that point. So this shows the waivered providers. Every one of our sites added waivered providers, and there was a statistically significant increase in the number of providers with a mean of adding 5 per site. Every site also showed an increase in the number of patients receiving prescriptions. Again, statistically significant increase with an average of 21 additional patients per site. And you can see wide variability in that. And finally, with the SUD16 measure, again, every site showed an increase in their percent of patients receiving medications, a statistically significant change of about 7% on average. So I know it was on the slide, I forgot to say it, but each one of our intervention sites was matched with 2 to 4 control sites. So if we look at the intervention sites compared to the control sites, the matched control sites also showed significant increases on all 3 of the variables. So then we were looking at difference in difference to see, well, is our increase bigger or better than the control sites? So the intervention sites had a significantly greater increase in the number of waivered providers compared to the matched controls, but the increase on the patient level variables was not significantly different between the sites. So what I'm hoping is this is just 6 months, so if they have added providers, hopefully that will translate into a bigger increase on those patient level variables as we go forward. And then also thinking about so each site had their own match controls. So if you compare them only to their own match controls, you can see that most of the sites outperformed most of their match control sites on waivered providers and on patients receiving medication or receiving buprenorphine. When it comes to the SUD16 measure, the percent of patients with OUD on medication, not quite as impressive. And I think our next talk may help to explain some of that. So just to conclude, I think it's a strong signal of an early impact, suggesting, as I said, possible additional impact on those other variables as we continue moving forward. Our sites outperform many, but not all of their control sites. And again, as Eric already pointed out, there are so many other efforts going on, both within VA and within the states and at the national level, that are targeting these exact same outcomes. So being able to tease out like this project versus SCOUT versus, you know, all the other things going on is going to be a really challenging for all of us. So I just want to thank, I've already mentioned Adam Gordon. I have a bunch of co-investigators, Minneapolis, Palo Alto, and Salt Lake City. And thanks study staff and also the implementation teams at all 8 of our sites who really are putting in above and beyond. I mean, they're not getting any, you know, release time or anything like that for the work that they're doing. And I just want to say that I love qualitative data. I couldn't fit it into the presentation, so I have a poster coming up right after this session if you want to hear about the qualitative data. So I don't know if I left any time.
Yes, you did leave time for 1, maybe 2 questions.
Your freedom pain management. You know, as you look at it, I mean, all this is very important work. Try to understand what are the barriers, what are the gaps, and how can we close this. And I think looking at the number at the site that had the lowest number of prescribing, you know, I think that's phenomenal. That's great work.
You.
Now, what I'm wondering is, as you make that intervention, was there some kind of increase of support to these providers? You know, did they implement the nurse care or some kind of other, you know, provider support, nurse case management support, like what is, you know, implemented by SCOUT or what is recommended by SCOUT, or a similar way? Did they give them more time on their panel? Because the moment people hear, obviously, that there's an invention or we are part of a study and, you know, we are being targeted as being more performing, maybe other things happen. So I'm just wondering, especially in the comparison to the control sites that you had, I mean, are they adding on resources to try to address this in addition to X-Waiver? Because that's what we hear from providers often. The reason why I'm not prescribing is because I don't feel my hospital, my facility, the system isn't truly supporting me for this.
So I would say that having resources added on was not common whatsoever. And we went from the very start, we said, we're here to help you solve a problem. We can't give you anything in the way of FTE or anything like that. I'm trying to think, we might have had like one site where leadership actually, you know, reduced someone's panel or something like that, but additional resources were not common. Every one of the sites, what I think is so cool is, you know, we presented them with options for models of how to do this, but we really let them come to the table and figure out what resources do we have and how can we rearrange them to make this happen here. So every site had different goals. Every site put together teams in different ways. I would say the one thing that really stood out for me is that we had presented the nurse care manager model, and a lot of the sites, and I've seen this in this project and also in Scout, a lot of the sites, what's available for them is pharmacy. I mean, pharmacy is like jumping to do this. So we have sites where the pharmacist is basically doing everything and the clinician signs the prescription. So that's, I think, a model that's really come to the top, both in this and in Scout. So. Actually, one of our sites is a Scout site. So, yeah, it's crazy. We started this project like a year before Scout even, came in. I'm sure it was in Karen's mind somewhere, but a year before anything concrete ever started to happen with Scout. And then, of course, it was huge panic about, what if our sites are Scout sites? The really interesting thing is that the VISNs selected facilities that were already doing well to go to Scout. So ours, by definition, were doing poorly. So we only had one site that is in both. And like I said, we're doing lots of qualitative work to try and figure out what actually spurred them. And they are the rock star. I'll tell you later.
Okay.